A continuación, la doctora Laryssa Athayde nos presentará la experiencia de implementación del tamizaje neonatal en Brasil. Bienvenida, doctora Laryssa. La doctora Laryssa Athayde es médica de la Universidad Estatal de Ciencias de la Salud de Alagoas, pediatra y genetista especializada en la Universidad de Sao Paulo y actualmente es médica genetista del laboratorio Mendelix Analysis Genómica. Doctora Athayde, bienvenida y adelante, por favor.
Hello, my name is Laryssa. I am a clinical geneticist in Brazil, and today I will talk about newborn screening in Brazil, past, present, and what we can expect for the future. I am a clinical geneticist at Mendelix since 2014. So, first of all, we have to understand why it is important to make some laboratorial screening in healthy newborns. It's a preventive action to detect in pre-symptomatic stage a disease that is potentially treatable. When we make an early diagnosis, we can provide adequate clinical intervention, the follow-up, and correct treatment, and improve mental and physical development. And this will reduce morbidity and mortality. With these actions, we can improve quality of life for 3 levels: individual, family, and society. And it must be offered for all newborn, even if there is no family history or consanguinity. Some people think that the newborn screening, especially the expanded newborn screening, must be offered only if the baby have a family history or for some disease if the parents are consanguineous. But what we see in practice is that most positive tests came from babies without family history. But how do we choose which disease will be screened? There are some inclusion criteria. We have to know very well the natural history of the disease. It must be detectable in pre-symptomatic phase, because here the main objective is to detect asymptomatic children who may develop symptoms. The result of the treatment in pre-symptomatic phase must be better than the treatment after clinical manifestations. And it must have an adequate test for early stage diagnosis. It must have a high incidence in our population. It doesn't make sense to screen an ultra-rare disease which we do not have in our population, for example. And we have to analyze the cost effectiveness of newborn screening and offer a good treatment for the disease. And how did it start in Brazil? In 2006, the National Neonatal Screening Program was started. It is a public health strategy carried out by our public health system that's called SUS. And it was divided in 4 phases. In 2006, we began with phenylketonuria and congenital hypothyroidism. In 2013, it began with hemoglobinopathies and cystic fibrosis. And in 2014, biotinidase deficiency and congenital adrenal hyperplasia. Today, we have some states that have already made the screening for more disease. It's expanded, but these diseases are the basic that all states in Brazil must provide. So today, in public health system, we screen for 6 diseases. In the private health system, we have already the expanded screening that can be offered by these 2 techniques: chromatography or tandem mass spectrometry. The number of diseases screened will depend on the technique used. Chromatography, which is a qualitative and handmade technique, will screen only for amino acids and will not screen for acylcarnitine profile. When this technique is used, we can screen about 33 diseases. And we also have the tandem mass spectrometry, which is a quantitative, automatic, and can screen both amino acids and acylcarnitines. It's considered today the gold standard, and when this technique is used, we can screen about 48 diseases. And again, it must be offered for all newborn, even if there is no family history and consanguinity. Recently, in May, the federal government has presented a new national program to expand neonatal screening to 50 diseases. It will be divided in these phases, so it will be divided in 5 phases. In phase number 1, it will be screened the phenylketonuria, the hemoglobinopathies, and congenital toxoplasmosis. In phase 2, it will be screened the galactosemia, aminoacidopathies, ureal sickle disorder, and fat acid beta oxidation disorder. In phase 3, lysosomal disease. In phase 4, immunodeficiency. And in phase 5, that is the last one, spinal muscular atrophy. And what we can expect for the future of newborn screening. We already have the molecular newborn screening, which complements and extends the traditional screening. We can analyze today more than 300 genes at once. It can screen disease that we do not have a biomarker to be tested in blood sample. This kind of test is currently possible as the cost of next generation sequencing, the NGS, has been falling year after year. And the molecular screening may help to elucidate a positive screening in the traditional test. And it may also suggest a diagnosis when the disease is not screened by the traditional tests. But always we have to remember, it is also a screening test, which means that if it detects something, it must be confirmed by another clinical or laboratorial test. For the molecular screening, we also have some inclusion criteria. We consider some of the criteria for the traditional screening, and we have a discussion with experts in different areas, neurology, nephrology, cardiology, immunology, and others, to choose which genes and disease would be included. The disease must have an effective treatment. We will not screen some gene that the disease cannot be treated. It doesn't make sense to know that your baby may develop a disease and we cannot treat that disease. And have a known genetic basis that can be investigated by NGS. For example, hypothyroidism have some causes that are not only genetic. So we cannot screen all forms of neonatal hypothyroidism. And adrenal hyperplasia has a molecular limitation by NGS technique, that is the CP21A2, that is the gene, has a pseudogene. So it's not possible using this technique to differentiate if the variant is in the gene or in the pseudogene. And as in the traditional newborn screening, the disease must lead to clinical manifestations in infancy. We will not screen a disease that will only have symptoms in the adult life, for example. And with molecular newborn screening, we can screen for disease in different systems: neurologic, endocrinologic, inborn metabolic disease, renal, and others. Molecular newborn screening has many benefits. The collect is very simple. We can collect DNA since the first day of life without a specific period, as in the traditional screening that must be collected between 3 and 5 days of life. And it's collected using an oral swab, which is easier, faster, and painless for the baby. It will be analyzed only the genes included in the test. We will not look for other genes that were not included. And only variants with potential clinical relevance will be reported. We will not report, for example, a variant of unknown significance. And again, it can be used as a confirmatory test for the traditional newborn screening. So if the traditional newborn screening suggests that the baby has, for example, cystic fibrosis, the molecular test can be used to confirm this diagnosis. These are the steps for the molecular newborn screening. So we collect the sample using an oral swab, as I said. Then the sample will go to the lab where it will be sequenced, and the bioinformatics team will organize the data and the medical team will analyze to provide a report. The results given in less than 4 weeks. Here, I would like to show you a schema of how we see the DNA sequenced using NGS. So these reads are of the patient, which are small fragments of DNA that will be aligned to the reference genome. These letters are the nucleotide bases, guanine, cytosine, adenine, and thymine. And in this first example, we see that in the position it was supposed to have a letter C, it has a letter C, so it's okay. It's not a variant. But in this second example, we see that in the position where it was supposed to have a letter C, we have a letter A, so this is a genetic variant. The report will show if the newborn has a high, intermediary, or low risk for the disease that were screened. Now I will present a clinical case to show how the molecular newborn screening can help to detect treatable disease. So the case is of a female newborn. We do not have additional information. It arrived for a screening, and we assumed that is an asymptomatic baby. It was detected 2 pathogenic variants in the mute gene, which leads to methylmalonic aciduria. This is how we see the variants in NGS using the IGV browser. So here we can see that it was supposed to have a G, and the patient has an A. And here we can see this little purple line that indicates that it has an insertion of some bases at this point. The first variant, where a guanine was replaced by an adenine, leads to a nonsense variant with a premature stop codon. And the second variant, where a thymidine was inserted, leads to a frame shift variant. Both are classified as pathogenic variants. After we did the molecular analysis, which was suggestive for methylmalonic aciduria, we received the information that the baby had this tandem profile with high levels of acylcarnitines. So the molecular test and the tandem profile were compatible with the diagnosis of methylmalonic acidemia, which is caused by methylmalonyl-CoA mutase enzyme deficiency. It can present with a severe or a mild form, depending on how much enzyme activity we have. The symptoms are acute attack of metabolic acidosis, hematological and renal symptoms. And the treatment is very simple. The baby must have a protein-restricted diet and use a specific metabolic formula, in addition to the use of intramuscular hydroxycobalamin, which is a vitamin. So, take-home messages. Expanded newborn screening and molecular newborn screening can be indicated to all newborns, even if there is no family history, even if there is no consanguinity. The molecular newborn screening does not replace traditional newborn screening. I show you some disease that we cannot screen using the molecular newborn screening. And the molecular newborn screening can expand the number of diseases that are screened. Here are the contacts and my email if you have some doubts. And thank you.
Muchas gracias, doctora Laryssa, por compartirnos una visión del tamizaje neonatal en Brasil y describir las acciones que se han venido implementando desde una estrategia de salud pública con el fin de desarrollar el seguimiento de enfermedades del tamizaje neonatal, ahora con una propuesta molecular.